the PMO academic program. The topic for today is management of type 2 diabetes. Our resource person for today is Professor Sachith Abhayaratna. He is a specialist in endocrinology attached to Faculty of Medicine, University of Colombo. He serves as the professor in pharmacology. Professor Abhayaratna completed his endocrinology training at renowned institutions such as Cambridge University Hospital and University College London Hospitals in the UK. He obtained board certification as a specialist in endocrinology in 2014. Additionally, Professor Abhayaratna has made significant contributions to the Sri Lanka College of Endocrinologists, serving as a council member and past secretary. His involvement extends to the Postgraduate Institute of Medicine, where he holds membership in the specialty board in endocrinology. Professor Abhayaratna serves as the current co-editor of the Sri Lanka Journal of Diabetes, Endocrinology and Metabolism. As a fellow of both the Sri Lanka College of Endocrinologists and the American College of Endocrinologists, he upholds the highest standards of professional excellence. Professor Abhayaratna's research work has obtained recognition within the national and international endocrinology forums and published in various well-recognized peer-reviewed journals. So let's listen to Professor Sachith Abhayaratna.
Thank you, Charani, for the kind introduction. So we will discuss today about the management aspects of type 2 diabetes. Now, I would like to give a brief outline of my lecture. So we'll first see what are the commonly used investigations in diagnosing type 2 diabetes and their pitfalls. And then I'll introduce you to this concept of cardiocentric approach in diabetes management. And then we'll see about the treatment options and how you select the best medicine depending on the patient. And finally, briefly, I will introduce you to some of the exciting new developments in the diabetes management. So with that, we'll move on to the lecture. Now, first, I would like to introduce you to this pathophysiology concept. I'm sure you're familiar with this. We all know that diabetes is a disease where there is insulin resistance as well as depletion of the beta cells leading to reduced insulin secretion. So those are the two main pathophysiological issues in diabetes. But apart from that, there are multiple other pathophysiological factors which lead to hyperglycemia. For example, there is glucagon-induced increase, unregulated production of glucose from the liver. Then there is increased glucose reabsorption from the kidneys, and there's decreased incretin effect, as well as neurotransmitter dysregulation in the brain as well. So these pathophysiological abnormalities are the targets when the new molecules and the new medicines are developed against the fight of diabetes. So when we go to the section of diabetes medicines, you can appreciate that some of the new medicines will target multiple pathophysiological issues in diabetes. So with that, we'll go to the investigations, what we do for diabetes. I'm sure you are all are familiar with all these investigations, but I'll quickly run through them. So when we suspect diabetes, we do fasting blood sugar. So general duration is 8 hours, non-caloric diet, fasting. Then we do the fasting blood sugar, and the value above 126, then you need to repeat that, and if it is confirmed, that we can use to diagnose diabetes. The other tests which we use are the 2 hours or the random blood sugars or OGTT, oral glucose tolerance test. Anything above 200 in these tests will also indicate diabetes. So if the patient have symptoms and if you get a random blood sugar above 200, even with a single test, you can diagnose diabetes. And the other one which we commonly use is the HbA1c, which you all know gives a 3 months average blood glucose level. So that above 6.5, even with a single test, we can diagnose diabetes. So these are the tests which we do to diagnose diabetes, but it's important that unless they have symptoms and very high blood sugar levels, you need to repeat them and confirm that before you decide on treatment. Now, between diabetic glucose values and the normal glucose value, there lies another category which we call as pre-diabetes. So if the fasting blood sugar levels are between 100 to 125, or in the OGTT, if the sugars are between 140 to 199, or if the HbA1c is between 5.7 to 6.4, that is considered as the pre-diabetes level. So the problem with pre-diabetes is if the patients don't do anything, at least the lifestyle modification, there's a 5 to 7% chance annually for them to progress into diabetes. The other thing is, even at pre-diabetes level, they have shown that there is risk of some complications with diabetes. So this category also we need to monitor and follow up. Now, HbA1c is a quite useful test, and there are some pitfalls in assessing HbA1c. So I would like to give a little bit more details about that. So as you know, it gives a 3 months average blood glucose level. But one of the important things is that when the HbA1c is done, it should be done in a standard laboratory. And they should adhere to this National Glycosylation Standardization Program standards, which has been set. Those standards has to be adhered. Otherwise, certain labs, when they do HbA1c, the report may not be reliable, even though it's a very good test, and you may not be able to go solely on that report. Now, it's important to note that HbA1c is not recommended in diagnosing type 1, or it's not recommended in diagnosing gestational diabetes, because sudden changes HbA1c will not be able to capture. So therefore, in these situations, it's not used for diagnosis. But all the patients, you can use the HbA1c for monitoring purposes. Now, HbA1c, we can relate it to the mean plasma glucose level. So most patients, we target HbA1c level of 7. That is roughly around mean level of 150. You will also see these new units, IFCZ units. That's the kind of standard units where the reports are now being transformed to. So most of the time you will see the percentage, which we are more familiar with, as well as the millimoles per millimole level of HbA1c. Now, I'd like to highlight 3 scenarios where your HbA1c is discordant with your fasting blood sugar levels, and we'll see what could be the possible reasons for these situations. So, patient number 1 comes with a fasting blood sugar of 160 and a HbA1c level of 5.6, and the patient has all the symptoms of diabetes, and you might wonder what this situation is. Now, there are few possibilities in this situation, but first thing, as I mentioned earlier, you have to check whether this HbA1c report is a reliable one. Although fasting blood sugar, many labs would be able to do it without a problem, HbA1c has to be done in a standardized method. So most common reason what we see is lab report error with the HbA1c. So the other things could be that patient had a prior good control, but recently probably consuming too much of high caloric food and sweets, the sugars is going to increase recently. That's another possibility. And we also have to look for, there are some other pitfalls. We'll go through that when we come to the next cases. Now, case number 2 is a situation where you find patients, it's a non-diabetic patient. Patient's fasting blood sugar is 113. As you know, I'm sure this is a good control level, but the HbA1c is around 7. Again, if you look at those mean plasma glucose and the what denotes by the HbA1c, you can see if HbA1c is 7, that means around 150 around mean level. So this is lower than that. So in such a situation, you have to wonder whether what is the reason for this kind of a discordance. So one common thing what we see in our patients is that prior coming to the clinic visits, patient become very careful with their diet. They might skip their dinner and they get a good fasting blood sugar level. But that denotes the importance of doing HbA1c. Still you see if there is any discrepancy with those fasting as well as HbA1c levels. And the third one, the patient again, let's say now this time diabetic patient on treatment has done the test in a good standardized lab. Still you find that fasting blood sugar is high and the HbA1c is low, which does not tally. So in this situation, you have to think about things like whether there are any other factors which could affect the HbA1c levels, which you get falsely low HbA1c level. So there are some situations that also it's better to be mindful of. So if you can go through that. Now HbA1c assess glycosylation of the RBC or red blood cells. So if there are problems with the hemoglobin count or red cell turnover, then your HbA1c is not going to be a reliable marker. So I have listed here multiple causes which either increase, falsely elevate HbA1c or falsely reduce HbA1c level. So if there is decreased RBC turnover like iron deficiency anemia, folate deficiency, certain laboratory interference like hypertriglyceridemia, uremia, etc., those will interfere with the assessment and can cause falsely elevated HbA1c level. Whereas other situations where there is increased RBC turnover like acute blood loss, hemolytic anemias, red cell transfusion or blood transfusion, those can lead into falsely reduced HbA1c level. So this highlights the fact that you can't go with a single investigation. No matter how reliable it is, you can't go with a single investigation because there are limitations for all these tests. So when you assess the patient with diabetes, you have to do multiple tests to see the best control. Right. So with that, we will go ahead with the part of initiating management and how to monitor the progress in these patients. So I'll first start with this pre-diabetic group. Now, you may have heard about this study called Diabetic Prevention Program or DPP study, which showed that in pre-diabetic patients, if you do intense lifestyle control, that can lead into 58% reduction of changing to diabetes. And in the same trial, they had another arm which they gave metformin instead of the intense lifestyle control, and the reduction was less than good lifestyle control, is about 31%. So based on this, all the current guidelines will recommend if you are in the pre-diabetic range, you should start with intense lifestyle modification. Now, different medicines have been tried in this pre-diabetic group in an attempt to delay or even prevent type 2 diabetes. That differentiation is not very clear. We don't know exactly whether this delaying or whether actually it prevents it. And the most commonly, you can see there are multiple medicines have been tried with some success, but most commonly used medicine in this regard is metformin. That's where we had a lot of data. And for the current guidelines, they recommend metformin in this pre-diabetes group, particularly if they have pre-diabetes plus some of these other additional risk factors. For example, obesity, particularly BMI more than 35, age between 25 to 59 years, because in older age group, we don't have much evidence for prevention because of the age. And then higher plasma glucose levels, for example, fasting more than 110, HbA1c more than 6. So those patients are at very high risk of progress into diabetes. And prior history of gestational diabetes. So if the patient has some of these additional risk factors, they may be candidates for metformin therapy in addition to intense lifestyle modification, which seems to be the best at the moment. Now, Previously, when we were treating diabetes, the focus was on treating hyperglycemia. But we know, even though we treat hyperglycemia, there is a lot of cardiovascular related deaths happening in this patient, because 2/3 of our patients die mainly because of macrovascular problems and the cardiovascular issues. So therefore, the treatment emphasis has now shifted to being glucocentric to more cardiocentric. At the same time, weight-centric management is also important, because we know, just like blood glucose, weight can also increase most of the complications similar to diabetes, particularly the cardiovascular complications. So currently, when we are treating a patient, not only the blood glucose control is our target, we also need to reduce the cardiovascular risk of these patients. Now, I want to show you about this interesting randomized clinical trial called DIRECT study. Now, what they did was, patients who were diagnosed with within 4 years of diabetes, they gave intense nutrition plan for targeting weight loss. And if you concentrate on the right side graph, as you can see, based on their weight loss, the remission, completely being off medicines, what we call the remission of diabetes percentage, dramatically increased. So those who were able to achieve 15 kilograms or more of weight loss, 86% of them completely went into remission of diabetes. So based on these data, we now take that weight management is an important part of diabetes control, even though now, even at lower categories, even though they might not go into complete remission, their requirement for medicines will come drastically down if they achieve a significant weight loss. At least we would try to target 5 to 7% of weight loss, which has shown good results in most of the studies. So when you are starting treatment, first is the diet and lifestyle. So generally, at least 5 to 10% of weight loss is recommended in all these patients, particularly if they are obese, in the obese category, if their BMI is high. And this should be achieved through a calorie-restricted diets. And other risk factors, like which can lead into risk factors for cardiovascular disease, like saturated fat intake, trans fat intake, they should also be reduced, and salt intake should be kept to a very low level. Now, I'm sure you are very familiar with these diet plans. The simple method what we use is this plate method, where the carbohydrate portion should be about 1/4 or 1/3 of the plate, and rest should be supplemented with vegetables and the protein items. Now, a diet is a good method. If it's adhered, it's a good method to bring down the glucose levels. But most of our patients, when we start treatment, we start pharmacological therapy, particularly metformin, along with diet. The reason for that is, if you stick to diet only, it will take time to achieve the ideal target. And we know that most of our patients, they don't stick to a particular diet plan, although they might stick it in the initial phase, but the compliance with diet is not that great. That's our general experience. So in our guidelines, Sri Lankan guidelines, most of the other countries' guidelines as well, they recommend starting combination of lifestyle therapy as well as pharmacological therapy at lower doses, not very high doses, to achieve the control quickly and to maintain it. Now, exercise is important as well, because they improve the insulin sensitivity, which is one of the core pathophysiological problems in diabetes. So the recommended is any aerobic physical activity, at least 150 minutes per week. So it's like 30 minutes for walking at least for 5 days per week, or you can at least do it. Minimum time is at least you need to do 3 times. You can't do 150 in one day and try to complete it. The benefits are less if you just do at one go. At least you have to do divided session. Minimum is 3 times a week. Obese patients, the limits are higher than that, because we want to achieve weight loss as well. So they are recommended to go exercise on for 60 minutes per day. And then in addition to this cardiovascular exercise, muscle strengthening exercises are also recommended, because we know when the muscle mass is high, muscles take up more glucose, and that helps in diabetic management. Then the next important thing is the glycemic targets. Now in general, in most of the patients, we would like to achieve the target of HbA1c of 7. That will denote to fasting blood sugar between 80 to 130 and a postprandial less than 180. But depending on the patient, you have to select your glycemic targets. This should be individualized target, because if the patient is very old, has multiple comorbidities, then we don't try to achieve this 7%, because most of the time then patients will go into hypoglycemia, which will lead to more complications than sometimes of the diabetes. So therefore, if it's very advanced age, multiple comorbidities, even HbA1c target of 8 would be suitable. Whereas if it's a young patient who is well motivated, no other complications, then 6 or even 6.5 up to 6 to 6.5 would be reasonable targets. Now, although we set these targets, it's not very easy to achieve these targets. And not only in our country, if you look at some of the other countries like States or UK, only about half the population achieve these targets, because there are multiple reasons. One thing is late diagnosis of this condition, late initiation of therapy, and then we know the response to therapy is not that good, and then hesitancy to intensify therapy, sometimes on the doctor's part also, which we call clinical inertia. We see this, and then patients give multiple excuses. They will say they have gone to a lot of weddings or a lot of other, taken some other things, and they want more time, and then we tend to give in to their request as well. And therefore, these uncontrolled levels goes on and on. And then sometimes, even though we prescribe the correct doses of medications, patient may not take them because they might get adverse effect. Common as these, insulin when you give hypoglycemia, and then thereafter patient will not take the prescribed amount. So adverse effects are also a problem. And then secondary drug failure, we know most of the drugs which we start, with time the response become less and less, and therefore we need to intensify therapy. And then there are many other factors, patient-related factors, their psychological status, family background, and sometimes if medicines are not available, then they have to buy it outside, then cost becomes a huge problem in these achieving these targets as well. And then I have listed here the common treatment options which we have and the pathophysiological mechanisms. For example, sulfonylurea group, they increase the insulin secretion, and then for the increased glucagon secretion, we have other therapies like GLP-1 receptor agonists, DPP-4 inhibitors, like that. I'm sure you're familiar with all these things, so I don't need to go through them details. But when you look at the individual drugs, I'll highlight them a little bit later. So these are the different options we have, and this is what the underlying pathophysiological problem they will adhere to. Now, metformin has been the first-line therapy in type 2 diabetes for a long period of time. The reasons for that is it has a very good glucose-lowering efficacy. It has shown cardiovascular risk reduction, particularly in obese patients in the UKPDS trials. And then it has low risk of hypoglycemia, modest weight loss or weight-neutral drug. It's inexpensive, commonly used drugs, and which were the reasons why it has been on the top for a long period. There are a few limitations. If the kidney functions are low, like GFR is below 30, you should not use it. GI adverse effects are common, but they get used to it, and you can start with low dose, and after meals can tackle these problems. The risk of lactic acidosis is very rare, But you have to particularly select the patient. If you select the patient carefully, it is rare. But generally, in kidney impairment, severe heart failure, liver failure, and those situations, we might not use metformin. And one other thing is that for long-term use, metformin can lead into vitamin B12 deficiency. It may be a good thing to supplement that in these patients. Now, sulfonylureas, there are many in the market. So these are very good drugs as well. That is one of the mostly available drugs or mostly used drugs in our country. They stimulate insulin secretion, relatively inexpensive when we compare with other therapies. We have a lot of experience, and they have shown to reduce microvascular complications in the UKBDS trial, although we don't have any direct evidence of macrovascular risk reduction like cardiovascular risk reduction with this group. So limitations are that it can lead to weight gain, and then hypoglycemia is one of the biggest problem, particularly if you use drugs like glibenclamide. They have a longer duration of action and tend to cause more hypoglycemic episodes. And the durability wise is low, which means that the time period which it can control blood sugar seems to be lower than other agents like metformin. The reason they have highlighted is that when you stimulate these beta cells more and more, their lifetime might get reduced, and therefore these drugs will not work for a long period of time. And then there are some concerns, particularly this blunting of myocardial ischemic preconditioning. Although we don't have direct cardiovascular endpoint trials, particularly with drugs like tolbutamide, there has been some concerns, which is a first generation sulfonylurea. There has been some concern, but this second generation sulfonylurea, particularly glycoside and glimepiride, they have not seen that much of cardiovascular adverse effects, although we don't have endpoint cardiovascular studies. Now, pioglitazone, which was a very good drug and which was used to be used frequently earlier, but nowadays it has gone out of fashion because of some of these side effects. It also has, it improves insulin sensitivity. It's a durable anti-hyperglycemic effects, minimum hypoglycemia, some favorable lipid impact on the lipid profile. And one of the drugs in this class, particularly rosiglitazone, had some concerns about cardiovascular effects, but later on that was withdrawn, but now the drug is anyway not in the market. Those problematic effects have not been shown with pioglitazone, but in fact, in some of the recent studies, it has shown that in stroke patients, this is beneficial in reducing, or high-risk patients for stroke, it might reduce the prevalence of strokes. So there is some positive effect on that aspect, but issue is some of these side effects. That's what discourage people using this drug. Particularly, it causes fluid retention, leading to worsening of heart failure, increased body weight, and then it can reduce the bone mineral density. So it's not a good drug at all in patients with osteoporosis. And there is some risk with bladder cancer, although it's a small risk. If you use it a long period, more than 2 years, the risk might accumulate. And then alpha-glucosidase inhibitors, again, it's not a very commonly used drug purely because its effect is very small, but it may be a suitable option in certain patients who has increased postprandial glucose levels, particularly patients who are not adhering to dietary guidelines, taking a lot of carbohydrate-rich meals. This might reduce the glucose absorption. Again, it's a very small effect. By its own, it can't control. It may be add-on therapy, but in Sri Lanka, we see that the cost of these medicines are high, which is another limitation. It's not good in when the patient has other complications like liver problems or renal impairment. Now, the more interest recent times have been drawn to these medicines like these SGLT2 inhibitors. So this is a medicine class where we know that SGLT or sodium glucose cotransporters, they reabsorb most of the glucose which is going past the glomerulus. But if the mechanism of these drugs are to inhibit that absorption, and thereby it promotes glucose diuresis with the urine, and with that follows some water diuresis as well. So these drugs have shown to reduce glucose as well as some cardiovascular benefits and renovascular benefits as well. And because the glucose is excreted via urine, it reduces the calories, and that helps in weight reduction. Now, these are oral group of drugs, and their benefits, they have a modest glucose efficacy. They are less than metformin and sulfonylurea, but reasonably good one. But it can lead to weight loss, which can give you some additional glucose lowering as well. Because they reduce the volume in form of diuresis, they reduce the blood pressure, and with these mechanisms, as well as there may be some other mechanisms which we may not know, they have conclusively shown to reduce the cardiovascular disease. And the new guidelines recommend, although manufacturer will not advise these levels, the new guidelines will recommend that you can go up to even low as GFR of 20. You can start this treatment and continue. Their limitation, biggest limitation is this increase in genitourinary mycotic infections, because glucose is passed with the urine. And there may be some doubt about this possible bone loss, and hypotension can be an issue because of the dehydration it might cause. And although it doesn't cause hypoglycemia, it's important to remember if you combine it with insulin or sulfonylurea, it will lead into hypoglycemia. So just want to show you the landmark trial, EMPOWERAGE trial. This is with empagliflozin, which shows from the early stage of use, it lowers the cardiovascular mortality and other cardiovascular events. You can see the separation of the graph starts quite early in these medicines. And with other drugs in this group, canagliflozin and epagliflozin, similar cardiovascular outcome benefits have been shown. Other than cardiovascular benefits, they have shown to reduce the renal tubular glucose reabsorption. They reduce weight, blood pressure, interglomerular pressure, albuminuria, and they have also shown to reduce they also slow down the GFR loss in these diabetic patients. So some are dependent on glucose control, others are independent of that. Therefore, so this is the landmark trial for the renal outcomes. This is the EMPOWERAGE outcome trial. That again, you can see with empagliflozin, there's a very clear advantage. So therefore, new guidelines will recommend this SGLT2 inhibitor should be given to all patients with CKD stage 3 or higher, regardless of their glycemic control, to slow down the CKD progression and reduce heart failure risk independent of glycemic control. Because they reduce the volume, they are a good treatment option in heart failure, irrespective of whether they have diabetes or not. Now, the second category, which have drawn a lot of attention in recent times, although we don't use it in Sri Lanka that much because of the availability issues as well as the cost issues, is these incretin-based therapies. So, incretin is a gut-derived hormone. There are two major hormones, GLP-1 and GIP. So, most of the therapies are mimicry molecules of GLP-1, and so they have multiple mechanisms of actions, which one of them is to increase the insulin secretion and thereby achieve very good glucose control. So this effect was evident when people observed that when you give oral glucose load and similar intravenous glucose, there is a difference in insulin secretion. And when they studied it further, they realized that incretin hormones secreted from the gut in response to oral glucose load further improve the insulin secretion and control the blood glucose levels. Now, there are two categories which come under incretin drugs. One is these DPP-4 enzyme inhibitors. Now, DPP-4 is the body's natural hormone which causes degradation of the incretin hormone. So, body's incretins will have a very short half-life because of quick degradation. Now, the DPP-4 inhibitors inhibit this enzyme and prolong the effect of the natural incretin hormones. So these are good drugs. Efficacy-wise, they are less than metformin and sulfonylureas. They have low risk of hypoglycemia because it's a glucose-dependent insulin secretion. Weight-wise, they are weight neutral, and they can be used in renal dysfunction, but some dose adjustment need to be done except for linagliptin, which is not secreted mainly via kidneys. So limitation-wise, they have modest HbA1c lowering. Sometimes there's a small link between acute pancreatitis, so therefore better to avoid in any patients with pancreatitis. And one of these drugs, interestingly, called saxagliptin, showed increase in heart failure when it was given, particularly probably because it caused a little bit of fluid retention. But other drugs, like the commonly used ones like sitagliptin, that effects has not been shown. So if there's heart failure patient, better not to use saxagliptin. And the other problem, limitation in Sri Lanka is the high cost of these medicines. Now, although DPP-4 inhibitors increase the body's natural incretin hormones, that is not a great effect. So thereby, they designed another molecule which is called GLP-1 receptor agonist, with modifying the peptide chains, and they will now not undergo degradation from the DPP-4 inhibitor. So they have a prolonged duration, which means they have a higher effect than the DPP-4 inhibitor. So these medicines have shown some additional things like reduced satiety, delays the gastric emptying, weight reduction, whereas DPP-4 we didn't see that much of weight reduction, but the exaggerated ones like these ones cause weight reduction. Some of the side effects wise, they cause commonly nausea and vomiting. So when you start with the low dose and increase, and then pancreatitis again to avoid. And there are some concern with C-cell hyperplasia, which is shown in animals, may not be relevant in humans, but in medullary or MEN syndromes, better not to use it. Now, the new treatment in these ones have gained a lot of popularity with patients, particularly ones like semaglutide, which is very potent and once weekly injection. I've also used it in few patients and they do extremely well, and their other drug requirements goes quite down with weight reduction with these agents. Now, just like the SGLT2 inhibitors, these agents have also shown cardiovascular risk reduction. It started in midway, if you look at the graphs carefully, when you compare with the SGLT2 inhibitors, and here they think it's more like they influence the atherosclerosis process, which is a slow process, whereas in SGLT2 inhibitor, it's the hemodynamic effect by controlling volume, which starts as a quick effect. But these drugs have conclusively shown, most of these GLP-1 receptor agonists have shown cardiovascular risk reduction. So we have gone through some of these important medicines available for the diabetic patients. So I think now it's important that we see how we should select these drugs based on the patient's characteristics. So we need to see the duration of diabetes, then see what is the HbA1c target which you want to achieve, and then what are the dosage forms available, whether it's oral, injectable, because based on that patient preference may also change. And then what is the degree of HbA1c lowering you need to achieve. Say a patient comes with HbA1c of 10 or 12, and if you want to achieve something like 7, certain drugs may not bring it down to that level. And then you need to see the adverse effect profile and contraindication of some of these drugs. And then particularly you need to see the comorbidity, particularly the cardiovascular risk, because as I mentioned earlier, cardiovascular risk reduction is one of our main aims when we treat diabetes. And then chronic kidney disease, other problems like osteoporosis. So based on the other comorbid condition, your selection may vary. Now, although it may be not quite visible, I'll go through this. This is the latest guideline, which is the 2023 ADA guideline. Now, I'm sure you are familiar with because this guideline has been there from 2021, 2022. They had a similar structured guideline. Now, up to last year, 2022, and Sri Lankan College of Endocrinology's guideline also came in 2022. They were based on the ADA inputs as well. Now, up to last year, it was when you diagnose diabetes, the first line of treatment was metformin. Whether they have cardiovascular disease or whether they don't have cardiovascular disease, your first line of management is metformin. And when you select the second line of drug, based on the cardiovascular risk, you can go for things like SGLT2 inhibitors and GLP-1 receptor agonists if they have high cardiovascular risk. Now, in 2023 guidelines, with accumulating evidence, now they have changed it. So, in the high cardiovascular disease risk category, metformin is not the first line. They recommend you go for one of these proven medicines because their effects have been much more evident than with the older used drugs. However, in Sri Lankan guideline, we still stick to metformin because some of these medicines are not widely available, and even if they are available, their cost will not be, most patients will not be able to bear that cost. So we go with the metformin and then we go with this. So I'll highlight the other areas as I go on. So if they have atherosclerotic cardiovascular risk factors, hypertension, dyslipidemias, etc., then the recommended therapy is GLP-1 receptor agonist or SGLT2 inhibitor because of the previously shown beneficial effect. And if the heart failure is predominant, then the SGLT2 inhibitor would be the best choice in these diabetic patients, along with other heart failure therapy. After that, you can add any of the other agents, but better to avoid agents which can aggravate this condition. The shift of treatment is for the microvascular complication, we mainly go with glucose control, but for prevention of cardiovascular disease, we mainly go with the more than HbA1c, we go with the evidence of medicines which have shown to reduce cardiovascular disease. Now, I want to show you this. Now, two commonly used medicines in reducing cardiovascular disease risk are statins and antihypertensives. So, if you look at 5-year data, the number needed to treat to prevent one death is 100 for statins, 125 for antihypertensive, which is pretty impressive. If you apply this for a larger population, you can see you are preventing many deaths by using statins and antihypertensives. And if you now compare the SGLT2 inhibitors and GLP-1 receptor agonists, you can see they have similar efficacy just like your statins and antihypertensives. And this has been shown even at a lesser duration. For example, 3 years, you get, if you treat with them for 3 years, every 100 patients, you are going to prevent 1 cardiovascular related deaths. So therefore, nowadays, with this strong evidence coming through, these agents are coming as the first line agents, particularly if the cardiovascular disease risk is high. And then these ADA guidelines also show other pathways based on the what is the main concern. If it is avoiding hypoglycemia as the priority, they would advise to avoid sulfonylureas and go for the other treatment. If the weight loss is the priority, again, GLP-1 receptor agonists and SGLT2 inhibitors are the better options. And then the cost is a priority, which I think we have to consider seriously. We have the options of metformin, sulfonylureas, and some patients, particularly if they have high stroke risk, the pioglitazones would also be a suitable options. And then if those are not enough, insulin would be the next line of management. Now, when you're starting therapy, if when they are coming for the first time, if the HbA1c levels are very high, it would be better to start them with combination therapy, because if you start with a single therapy, it will take longer time for achieving the blood sugar control. This is quite similar to the blood pressure control. If the blood pressure is very high, we go with the combination therapy. And then we all know that with time, the insulin secretion decrease and most of the drugs like metformin, sulfonylurea, their efficacy will go down as the number of insulin secretion cells go down. And what we commonly see is that there is a undue time taken to shift and intensify therapy. So in average, they say that there's a delay about 5 to 8 years before initiating insulin therapy because of these delays which happen in these patients. Now, I'm sure you all know about the available insulin preparations. I have just highlighted some important aspects. So there are these fast-acting insulin. Now, the new addition is this ultra-rapid-acting insulin, which act even faster than the normal fast-acting insulins. Then we have the regular insulins, the intermediate-acting insulin NPH, and the analog long-actings Detamir and Glargine. Both are available in Sri Lanka. And then the new addition is this Degludec, which has about 42 hours and very flat basal profile, just like the body's natural basal secretion, which is not still available. Now, I want to show you a case just to highlight the fact how we start on insulin. Now, this is a patient, let's say, working in the municipal council, type 2 diabetes, 5 years, reasonable food control, no complications, good adherence, taking maximum metformin and glycoside doses. And if you look at the glucose levels, you can see HbA1c is 8.5, and then his after meal ones are between 160 to 180, but the morning ones are 160, again similar to that. So the main problem, as you can see here, is the fasting levels or the morning levels, whereas daytime levels are within the range. So when you see a patient like that, and if the patient is not in a position to afford drugs from outside, like the other ones which we discussed about SGLT2 inhibitors, etc., then the next best option is going to be the insulin therapy, because patient is already on to maximum doses of 2 commonly used drugs. So based on that, you can add a basal insulin in this patient because only the fasting blood sugar is high. So a suitable option would be the NPH insulin or isophane insulin, and based on the HbA1c level, you can calculate the dose per body weight for the body weight. So we generally start roughly about 8 to 10 units, and then gradually you have to increase based on the blood sugar level. Now, what is the situation about using oral drugs with insulin? Metformin we generally continue. Sulfonylurea sometimes we use, but if it's with basal insulin, most of the time you have to use, because daytime otherwise you will not get control. Pioglitazone probably avoid because it will lead to more weight gain. SGLT2 inhibitors, if they are on that, if they can afford it, retain if possible, because these have cardiovascular risk reduction. And then GLP-1 receptor agonists in other countries, they recommend continuing with insulin because they have these cardiovascular benefits and they lower the insulin requirement. Now in this patient, we have started NPH insulin 16 units at night. He got good control thereafter, but in few years time, he present again. Now his the fasting blood sugar levels are reasonable, but you see his postprandial levels are now in the higher range, 200 and 250. So what would you do now on basal insulin and metformin and glycoside? What would you like to do? Well, then you can select either, let's say if the lunch is only the high postprandial level, either you can add the short-acting insulin for lunch, or you change your insulin regime to go to premix insulin, where you give mixed insulin, premix 30/70 insulin, morning and evening, changing then ready. So if they are not achieved, most of the time we'll be able to achieve control. If they are not, very rare situations, basal bolus insulin regime may be needed, but that's only in a minority. Now, other than glycemia, there are many other factors which promotes macrovascular disease. For example, dyslipidemia, hypertension, obesity, smoking, and altered coagulation. Now, STENO2 study was one of the important studies which shows the intensive control of glucose, blood pressure, dyslipidemia lead to reduction in cardiovascular mortality. So based on that, we need to control the other parameters. So the target blood pressure for these diabetic patients should be less than 130/80, and ideally they should be started on ACE inhibitor or ARB. And if it is not controlled with that, you can add other available antihypertensive therapies. So if they're present with high blood pressure at the beginning, probably you can also consider combination therapy. Now, lipids are the other important factor, so you need to achieve those lipid targets. Based on the risk, the lipid targets what you need to achieve will vary. High risk, you need to achieve LDL target below 70, very high risk below around 55, or moderate risk around LDL of 100 would be reasonable. Now, statins are the most commonly used medicines to achieve these glucose level. They have the best evidence. Based on the cardiovascular risk, you have to decide whether to use it. But most patients, type 2 patients, when they are above 40, their cardiovascular risk is high enough to start a statin. What about antiplatelet therapy? Now, earlier we used to give aspirin for all the type 2 diabetes patients as a primary prevention, but secondary prevention, there's no doubt about it, you have to give aspirin. But primary prevention now, the thought is, you need to give based on the cardiovascular risk. If the patient had diabetes for a long time, a lot of other cardiovascular risks, probably aspirin may be an option. But newly diagnosed, no other cardiovascular risk factors, aspirin is not indicated. Okay, so I think I have covered most of the important aspect in management of diabetes. I just want to briefly show you some of the new development in the management of diabetes. It's a big area, but I just have selected 2 factors to show you. Now, we earlier discussed now if this 55-year-old patient present with fasting blood sugar of 120 and HbA of 7, would you be happy? I mean, in most situations, I mean, if you see that what we have discussed so far, we'll be happy. This seems to be good control. But I'll show you 3 patients who have HbA1c this level and the fasting blood sugar of 120. Now you can see here, they all start with fasting blood sugar on that day 120, but you can see the variation, right? So HbA1c is a combination between the average value. So it can comprise of high values and low values till you get HbA1c 7. But what you would like to achieve out of these 3 situations is number 3. Everything is in range. Because we now know that time in range is also important in getting these microvascular and macrovascular complications. So therefore, these new glucose, continuous glucose monitoring CGM sensors have been developed. So this is 2 commonly used CGM sensors in other countries. Unfortunately, we don't have them yet. This Dexcom and Libre 2, where you just insert the sensor and for about 10 days or 2 weeks you can wear it, and it continuously give every 5 minutes into a device or to your smartphone what is your sugar level. So the reports looks like this. You can see it's comprehensive. You get the target in range, high, low, very low levels. So if your target in range is good, that gives a better cardiovascular risk reduction. And then I'll show you finally this one of the new drugs which have come into the market, and this is in the 2023 guidelines. We discuss about the GLP-1 receptor agonist. Now there are 2 incretins. GIP is the other incretin. Now this is a dual agonist of GIP-1 and GLP-1, and although it may not be clear, all these graphs show that it is much more efficacious than available treatment, even more than GLP-1 receptor agonist, and the weight reduction is much more than available treatment. So now this has come to the guidelines and some other countries. I'm sure we are waiting for the cardiovascular risk safety profile. If that proves good, I'm sure this would also be a very popularly used drugs in many countries. And then finally, to tell you when would you think that the patient should be diabetes is commonly managed by any doctor, but some patients will need specialized care, particularly if it is type 1 diabetes. It should be managed by endocrinologists, because these patients, most patients we know have a very poor control and very early death. They have to be managed at a specialized clinic. And type 2 diabetes, most patients can be managed in primary care. And then atypical presentations like sudden deterioration of kidney functions might need kidney evaluation, uncontrolled with multiple therapies, and then advanced complications, they might need specialized input for better management. Well, I think that's it I have to discuss. If there are any questions, I'm happy to answer.
We have received a few questions from our participants. The first one is, what is the exact time duration for fasting when testing? Is it 8, 10 or 12 hours ideally?
8 is the recommended time, but sometimes when you do the lipid profile at the same time, we come to a compromise of 10. Because more you fast, your time you fast, your fasting blood sugar may vary. Yeah. So 10 would be a reasonable compromise, but 8 hours is recommended.
The question is, what is the best option if we consider side effects and the affordability for the patient, the best medicine?
Metformin and sulfonylureas are the cost-wise the best options in Sri Lankan patients. But if they are to buy a drug outside, I would say it should be SGLT2 inhibitors ahead of a DPP4 inhibitor, because benefits are much clear. And the cost-wise, what we see outside is they are similar. So therefore, third option, I would say, you can go for a SGLT2 inhibitors with the current. That's the third option. If they cannot go for a drug like that, insulin is also a good option, because most of the time our setup, it's metformin, sulfonylurea, and then insulin. But patients, particularly who have cardiovascular high risk, it's better before starting insulin, you go for a SGLT2 inhibitor. Yeah.
If the patient's fasting blood sugar is upper normal and PPBS between pre-diabetes range, what is your suggestion?
PPBS in the pre-diabetes range. Now it does depend. It will also categorize as pre-diabetes, because one factor is in the pre-diabetes range. So they can, the best shown evidence is for the lifestyle modification. So you go with the lifestyle modification and then you monitor the response. But if they're at high risk, which I showed you few characteristics, there may be some case for metformin, addition of metformin in few patients. But the first line would be diet and lifestyle.
Next question, fasting blood sugar is normal, HbA1c is 6.5. Then what is the suggestion?
Yeah, I think I showed you a few scenarios where there's a discrepancy between fasting blood sugar and HbA1c. So when you do HbA1c, you have to be mindful about the pitfalls like hemoglobin disorders, anemias, and those things might not give you correct HbA1c. And then commonest reason we see is the poor quality reports of HbA1c, which is not done in a standardized lab. And then other reasons you have to think is HbA1c is good. You said fasting is high, no? The fasting is normal, and the HbA1c is high because then when patients see that report, they modify their diet, they go for walking, and then they come with a good report and show you they want to get some assurance. So in that way, but still you can diagnose. If the report is reliable, you can diagnose they are in the diabetic range. So you have to apply the normal method.
Another question appeared, how long do we need to continue metformin for pre-diabetic patients?
Well, they have not defined any time. As long as your risk is there, you can continue. But let's suppose that patient did some significant weight reduction, probably you can come out of that because you are now reducing your risk. So you can yearly evaluate whether still you need to keep on. But all the same risk factors which you initially started prevails, you need to continue that.
So that's the question.
Yeah.
What I face, some patients they decide and they stop the treatment because they get sweating and all, like fluctuation of the level of the glucose. They think like they are getting reduced symptoms and all. So what do you recommend, like for the patients, like if they stop, or whether we can reduce the doses for the patients?
Yeah, it's a common scenario as well. So one thing we do is, if possible, we ask them to get a glucometer and monitor. So that gives the best support. And then sometimes these are related to the other circumstances. Sometimes they skip the meal, or they have gone for extra work or something. Suddenly they have developed it. So those situations we have to explain them, and they have to realize that this would happen, and they take precautions priorly, like snack in between would reduce most of the thing. So therefore, and if you see that there's a significant like severe hypoglycemias, probably as a precaution, particularly in elderly patients, as a precaution, we reduce the drugs like sulfonylureas. Dose we reduce a little bit, and we look at the reason why it has happened, and we try to address it, because most of the time otherwise patients will do it by themselves. Yeah.
Thank you very much for answering that long questions, and that concludes our program today. And thank you for joining. Have a good day.